Good morning to all of you, and welcome to this launch of Compassionate Ottawa's series of conversations with leaders. Bonjour et bienvenue au lancement de la nouvelle initiative de Compassion Ottawa. Je suis Monica Patton, présidente du conseil d'administration de Compassion Ottawa. J'aimerais vous parler un peu de qui nous sommes. I'm Monica Patton, the president of Compassionate Ottawa, chair of Compassionate Ottawa is what we call ourselves, and I'd like to take a moment and tell you a bit about us. Compassionate Ottawa is working to achieve the change in the culture of dying. A community movement, we believe that everyone should have the opportunity to enjoy wellness and self-respect until the very end of life. But we know that there is discomfort around end of life, around death and grief. That discomfort isolates people. It isolates those who care for them as well. So we help communities to help people deal with dying, death, and grief. We encourage people of all ages and all backgrounds to have conversations about dying and grieving with their families, with their social networks, in schools, in faith communities and workplaces, and in healthcare settings. We offer workshops. We hold public events like this one. We post relevant articles and research on our website. And we support two projects. One of them we simply call HELP, Healthy End of Life Project, and another, Caring, Sharing, and Preparing. Let's talk about later life. Both of these projects are aimed at building the capacity of the people in Ottawa to ask for and to give help, and to learn more about end-of-life issues. We're a group of community volunteers working in both English and French, and in partnership with others to engage our whole community in caring for one another. Today, we have a wonderful opportunity to continue to build our knowledge and our commitment to each other, especially during this time of pandemic. To introduce our two amazing conversationalists on the topic of end-of-life care is everyone's business is Jim Nininger, Compassionate Ottawa's co-founder and our first chair.
Thank you, Monica, and good morning, everyone. I would just like to take a moment to introduce our two panelists. Allan Kellehear, he's a professor emeritus at the University of Bradford in England. A look at his biography will show the seminal role that he has played in the compassionate community movement and the public health approach to end-of-life care. He has written extensively, including a number of books, and he has lectured throughout the world. He is founder of the Public Health Palliative Care International, which has an excellent website. He knows Canada well, having spent time at Dalhousie University. I had the pleasure of meeting Allan in 2017 when the international conference was held in Ottawa. I keep my notes from that time we spent together, Allan, and refer to them periodically as we continue our journey to become a compassionate community. Secondly, Mary Lou Kelley is an emeritus professor at Lakehead University and has spent her career teaching and conducting research in gerontology and palliative care. She is recognized internationally for her work, including her groundbreaking research with Indigenous communities and in long-term care facilities. I first met Mary Lou at a palliative care workshop in 2016, before Compassionate Ottawa was even an idea. She's had a huge impact on our initiative, including our sponsorship of Health Ottawa, which is a 3-year research project being carried out at Carleton University with financial support from the Mac Garrelson Foundation, as well as our Canadian Frailty Network project. Mary Lou is now located in Ottawa, and I'm particularly pleased to have her as a member of Compassionate Ottawa's Advisory Council. Mary Lou, over to you.
Thanks very, very much for the introduction. And Allan, what a privilege it is for me to have this chat with you today. I've told you this, but I'm going to tell our listeners that I found my academic home in your writing and your thinking about compassionate communities. I'm a social worker by profession, a gerontologist and palliative care educator and researcher. And I'd been working on the margins of my academic fields for most of my career. My work was not really mainstream in social work, gerontology, or palliative care, and may have even created some discomfort. But when I walked into my first public health and palliative care conference in Bristol, England, with my colleague and friend Denise Marshall, I instantly felt like this is my tribe, this is my people. And it was for sure. So I thank you for what you do.
Thank you.
So let's begin by situating ourselves for our listeners. Can you tell us where you are and what you're up to in 2020?
Yeah, so I'm Professor Emeritus at the University of Bradford, and I also work in our charity, a British charity called Compassionate Communities UK, with my colleague Julian Abel and Catherine Millington Sanders. Julian Abel is a palliative care consultant, and Catherine is a end-of-life care lead for the Royal College of GPs. I also divide my time between doing that and working voluntarily with the Royal College of GPs on their COVID-19 think tank. They've got a think tank group at the Royal College of GPs. So I'm basically doing those kinds of things. I'm still writing and traveling and speaking in between all of those things. I'm editing with Julian Abel the first Oxford textbook on public health and palliative care, and that's due at the end of the year. And editing the journal Palliative Care and Social Practice, which is our public health palliative care journal, but we call it social practice because it's inclusive of pastoral care and social work and social sciences, as well as public health palliative care more specifically. So that's basically what I'm doing these days.
Thanks for that. So people heard Jim mention that I was in Ottawa now. My husband, John Cosgrove, and I relocated from Ottawa from Thunder Bay, Ontario in July of 2020 to be closer to our 3 children and their partners and our 4 grandchildren who are all under the age of 9. So we're both retired now, and I was at Lakehead University in Thunder Bay, Ontario for 35 years. So it's really hard to believe I'm retired. John and I got involved in Compassionate Ottawa about 3 years ago, as Jim referenced, and we've both been volunteering with them ever since. In addition, I'm planning to facilitate my first online LEAP course for Pallium next month for some long-term care home staff, because long-term care has been a major focus of my work. And I'm still back and forth a lot to Thunder Bay. I have a 94-year-old mother there, 2 sisters, and another daughter and grandbaby. So I'm busy enough, but lovely to have time to do this with Compassionate Ottawa. So we'll turn to our first topic. Allan and I had a bit of a chat just to let the audience know that we're not right off the cuff. We worked out some key topics we thought might have been of interest to others. So the first one, let's begin, Allan, by discussing the basic principle of public health and palliative care. Why should end-of-life care be everybody's business?
Yeah, so that's a very big question, and it has an equally big answer. There are 2 or 3 things to say. The first one is to say, why shouldn't it be everybody's business? Health is everybody's business. If you're one of these people who think that health is something that you get from your local hospital or your family doctor, your GP, you're seriously wrong. Health is everybody's responsibility. Most people understand that. That's why they try to eat better and why they exercise and why there are policies in the workplace to protect workers and why there are policies in schools to protect students and to promote their health and well-being and protect their safety. We've gotten used to that idea. When you buy a car, you assume the wheels are not going to fall off when you drive it down the road, a mile down the road. And the reason for that is because car manufacturers have a responsibility for your health and your safety. Right? So it's the same when you build a house. There are health and safety policies and regulations and legislation to protect you so that when you walk into your house, it doesn't fall down around your ears. So people have come to the idea that health is everybody's responsibility. If that wasn't the case, our hospitals and our primary care facilities would be overwhelmed. Buildings would be falling on people, cars would be falling apart, people would run over people in the streets, people would be drunk all the time. That's not the way things go, because modern societies have health promotion, which is the idea that everyone takes a little bit of responsibility for their health. And when there's a crisis, we have services. And that is exactly the same for end-of-life care, exactly the same. And that brings me to the second point. The reason why it's exactly the same is because end-of-life care isn't just about terminal cancer, about dying people, and not dying people in the last 2 or 3 days. It takes a long time to die. And amongst people with life-limiting illnesses, they may live well for 2, 3, 4, 5 years. And there's also people with advanced aging, people who are long-term caregivers, which are part of end-of-life care. And also those who suffer from, who live with grief and bereavement. Bereavement doesn't last 6 weeks, and it doesn't last 6 months. It doesn't even last 6 years. It lasts forever. And the response to supporting people in grief and bereavement is not service provision. It's not service provision. If it was, every second person would be a grief counsellor. So that's nonsense, right? So unless we understand that outside the very specific acute model of palliative care and hospice care, the people who live with life-limiting illnesses and long-term caregiving and grief and bereavement and advanced aging are all around us. They're all around us. And it's not dying, and it's not bereavement per se, which is the problem, but the companions that follow that journey, those two journeys, the anxiety, the depression, the social isolation, the loneliness, the stigma, the social rejection, the job loss, the lost school days, the suicide, the sudden death. All of these things are amenable to prevention and harm reduction, and they can be done by you and me. And the reason why they can be done by you and me is what I call the 95% rule. And that brings me to my third point. Dying people and bereaved people spend less than 5% of their time face-to-face with a doctor or a nurse. Fact. 95% of the time, dying people and bereaved people and long-term caregivers, they spend that time alone, or with family, or with friends, or with their co-workers, or with their animal companions, or with the TV, or with the internet. So you've got to ask yourself, what are palliative care services, end-of-life care services generally doing in that 95%? And the answer is, historically, the answer is very little or nothing, depending on where you are in your circumstance. That 95% belongs to you and me, the community. And that's why end-of-life care is everybody's responsibility, because you have to ask yourself, where are the grieving people? And I can tell you, they're in the office next door, or they're in your office, or they're in your class, or they're in your shop, or they're in your museum, or they're walking down your street, or they're in your neighborhood. So the only way we're ever going to get a continuity of care in end-of-life care is, in fact, to take up everybody's responsibility for end-of-life care. That's why it's everybody's responsibility.
Allan, do you think that this issue of turning end of life over to the healthcare providers and the medical system is more an issue in the developed world and Western society? And I ask you that question because I did a lot of work in Indigenous communities here in Canada with Holly Prince. And one of the first things I learned was embedded in all of their cultural traditions were the values of a compassionate community, as I understand them to be, the community and the family taking responsibility for supporting one another through the journey. And I recently talked to a hospice volunteer here in Ottawa who was born and grew up in Holland, and she spoke about in her youth how dying was very much a part of the family and community, and it was common for people who were dying to either be cared for in their own home or go to the home of another family member and be cared for by everyone, including the children. So I just wondered if you had a thought on that issue.
Yeah, I mean, I have a couple of thoughts. I mean, one is that it has been the history of development and developing countries, and I use the term countries broadly here, not just referring to nation states, that as people develop, they move towards services. In Japan, for example, which is a society I have a lot to do with, I have family in Japan and I visit there a lot professionally. The care of the dying and the bereaved was a family affair traditionally. But now there's stigma if you don't send grandma to the hospital as soon as she looks pale. The idea of a good son is to make sure that your parents get the best medical services available. So there's been a shift since the Second World War in Japan between the idea of filial support and filial piety, if you like, filial support of parents and so forth at home, to transferring all of that stuff to direct service provision and health services and medical care. And that's not just Japan, that happens all over the world. It's one reason why we're there as well. So there's no doubt that rural societies and in many Indigenous societies, these kinds of domestic styles of care are the basic type of care. But as gentrification moves in, as they move into the wider workforce in their respective countries, as their economies develop, those very same people move towards direct service provision. That's what happened to us, and it's happened to many others as well. So that's the first thing. The second thing to say is I was in Ireland a couple of years ago, and I remember somebody from an audience said to me, you know, in Ireland, we traditionally looked after our dying, and then, well, a lot of that is disappearing now as we're sending people into hospitals and care homes. But I reminded that person that the traditional boast of caring for your elderly 50 years ago, 100 years ago, 1,000 years ago, was entirely different to looking after the elderly now. Maybe 1 in 100 families had an old person anywhere near them. People just didn't get old. One of the reasons why the old were revered is because if you got old enough to get grey hair, you must have been God's special child. So of course everybody's going to look after God's special child. But when you've got an old person on every street corner, things get a little bit more high pressure. the reality is most families are dealing with elderly people, and also life expectancy has multiplied exponentially the number of people with serious forms of cancer and degenerative heart and neurological diseases. Care of the dying 100 years ago in Ireland, in epidemiological terms, there is no comparison between that care then and care now. So there is a tendency to romanticize past care of the dying. When you consider that before a mere 100 years ago, most people died in their 30s and 40s. Cancer was a rare thing. A heart attack was an odd thing. These are the bread and butter of public health today. Most people have them. So the idea that families alone should bear that brunt is an anachronism based on a romantic idea. What is important, however, is that communities and families and their health services work together as a partnership. And hitherto, we've forgotten how to do that. And in some places, we've never done it since the Second World War. So the most important thing about compassionate communities, or the public health approach to end-of-life care, is reinventing and reinvigorating those partnerships between health services who bring special things to end-of-life care, and the family who bring even more special things to end-of-life care, and the community which can support both. That's the model.
Yeah, yeah, and yeah, that's terrific, Allan. And your words make me think too that another major change in society has been, in the developed world at least, how mobile people are.
Yeah.
I mean, back in the day, my husband and I were talking about this, like, people probably didn't die very far from where they had lived their whole life. People didn't travel and move around.
Yeah.
And so extended families are highly dispersed around the world sometimes, making the possibility that someone in need of support is isolated from immediate family members. And I think of the words of your colleague whom you referenced, Julian Abel, and said, you know, people have always been very kind and compassionate to one another. That's how we got through life. And maybe the challenge is that, in part, that we can't reach out automatically to our immediate family. They're not always there for us, and we need to reach beyond to our neighbors and our church communities and our work colleagues for some of those supports that we might otherwise have, you know, more naturally gotten within our family group. And that's a new experience.
Yeah, it is. It is. Yes, it is.
I'm going to introduce my shirt here, just because I think it's relevant to the work that we are trying to do. So as far as having a social movement, I encourage all of you to get a shirt that says, "Make empathy great again." So let me just see where I am here, moving us along.
Yeah.
So how do we, having talked about the things we've talked about, how do we get the message out to the broader community? How can communities be mobilized more proactively to reach out to their family, friends, and neighbors?
Yeah, I mean, there are two ways that this seems to be happening around the world at the moment. One is through compassionate communities, and the other one is through compassionate cities. And they're two very different public health methodologies. One is community development, and that's compassionate communities. The other one is compassionate cities, and that's often what's described as a social ecology framework or an ecological frame. And they both complement each other. But compassionate communities and compassionate neighbours, compassionate neighbourhoods, these are often groups of neighbours or villagers, small townsfolk who decide to have a town meeting and work out how they can address the 95% rule, how they can address the 95% of the time that people living with life-limiting illnesses or advanced aging or caregiving or grief and bereavement can be supported outside, visiting the local doctor or visiting the local counsellor or social worker. And usually those people self-organise and get together with these groups and change the way in which they decide to support people. They can provide simple things like transport and company. They can also do shopping and things like the sorts of things that we're used to hearing from hospice volunteers, for example. However, the other major difference is that we don't see people who are grieving or caregiving or living with a life-limiting illness as patients. So that we don't see them as people who are simply recipients of care. They're not charity cases, as we say in Britain. In a public health sense, what we are giving those people is an opportunity to give back. So we ask those people who we think are grieving or have some long-term caregiving or have a life-limiting illness, how they can also help other people who are grieving or living with life-limiting illnesses, or alternatively, how they can give to people who don't have those experiences, how they can help raise the community literacy about that experience, how they can share their experience and turn it into learning for the other members of the community. So they are active participants. They have agency. We don't view them as people who need our help. We're not just replacing the GP with ourselves, providing direct service provision. We're creating a partnership and a learning, an active community. So it's a two-way thing. In Compassionate Cities, what we're doing is we're phoning up local businesses, or we're going to the local Rotary or Lions Club or Apex Club, and we're engaging with business leaders. We may go to the Chamber of Commerce and give a talk. And we basically say, okay, so what are you guys doing for people with life-limiting illnesses and long-term caregiving responsibilities or grief and bereavement? And usually if you ask a group of business people this, the floor falls silent. Some of the best things I've heard is, well, we offer 3 days compassionate leave. That's my favorite. I love 3 days compassionate leave. If ever there was an argument for speed dating transferred to speed grieving, that would have to be it. The reality is, how do you support grieving people at work? Are you going to support people who are grieving at work? And if you're not, are you happy for those people to keep taking their sick leave from you that you are paying for when they use other reasons why they're not coming into work? So it's to all our advantage if workplaces start thinking about how they can support people with life-limiting illnesses, how they can support people who are older into work. And many of those older people have caregiving responsibilities. They may have an aging parent at home or a sick child with a life-threatening illness or a major disability at home. These things are important. They're important to workplace satisfaction, retention, reduction of sick leave usage, health services usage. And we do the same in schools. So Compassionate Cities, we go into schools and we say to schools, what are you doing for your students and your teachers and your parents and your administrative staff when it comes to the great issues around mortality? So Compassionate Cities are cities that decide that they will have policies and practices in every major sector. So it's not about just volunteering. It's about development of policies and practices in the major sectors of a place like Montreal or New York or Copenhagen. It's really about getting a coordinated effort, getting different parts of the city to talk to one another. In fact, Compassionate Ottawa is particularly well placed to bring the business leaders in and the faith group leaders, the bishops and the rabbis and the imams, and together and saying, what can we do with our faith groups? What can we do with our workplaces? What can we do with our schools? What festivals do we have annually, publicly, that showcase the issue of mortality? So it lifts the literacy, the end-of-life literacy of the whole broader community, and acknowledges and gives a place to people who are otherwise invisible. People living with life-limiting illnesses, the very old, the long-term caregivers, and people who are grieving and bereavement. And compassionate cities are about that kind of action. Compassionate communities are more local, but generally that's how those kinds of initiatives are spread.
So just to sort of summarize it, it's really both kind of a top-down leadership from community leaders, civic leaders, and bottom-up initiatives that local people can mobilize, identify how they want to reach out, creating that mutual aid. And I guess they're both important.
Yeah, I mean, they're both important. I mean, if you have a business with 500 employees, of course, you can develop your own policy of in your back office, in your spacious little brain, and how that might apply to 500 employees. But that isn't a good way to go about things. It certainly needs to start there. The owner of a business or a major manager should be able to think, we need a policy like this. What will be our approach to someone who's reacting to the suicide of a family member, or the death of a family member in an accident, or who is dealing with a spouse with a serious cancer or a child? But the best way to deal with that, of course, is community development, is community action. So it's to treat your workplace like its own little goldfish bowl. And you get those workers together and you say, ladies and gentlemen, we really ought to think about how we can support each other in times of crisis. And that may even mean supporting people during a marriage breakup. It doesn't have to be specifically about end-of-life care. Bereavement is only one sort of grief, and we can't be too, categorical and pure about end of life. Life crises are part of the broader issue of the grief, forget bereavement. So, and usually people respond really well, they're creative, and they can throw up ideas about how they're going to support each other during these kinds of things. And then every year, annually, they can look back at how well that went and revise it with practice wisdom. Those 500 workers will work out whether that policy really helped them or not, and how it can be improved. And so it's a dialogue which you start. But the most important thing about the leadership is that this is endorsed and encouraged within those businesses and within those schools and within those churches and temples and mosques and within the local government that prepares to make plans for public festivals and that kind of thing.
Yeah, I want to just add, two comments to what you said. Is in addition to having the senior people in the organization endorse, I mean, sometimes it's just really then important that they get out of the way and trust the people to find their way to the practices in the workplace that will work best for them. Because in my community development career, some of the things that they felt were important and they started with were very unexpected to me. If you had left it to me to predict, I would not have seen them as where they might start. So I do think having them get out of the way is a really important thing to do. I also like what you said about the mutual aid dealing with all sorts of personal distress, not just end of life, because it seems to me then we really are making a culture We are promoting the development of a new culture in the workplace or the school or the neighborhood where people help each other, and they don't necessarily need to distinguish, is this end of life? You know, that boundary gets removed, and that helping.
What we're looking for is a switch to a culture of compassion.
Yeah.
And end of life care is a very, very important part of that, but
Yeah.
not exclusively.
Yeah. 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 You referenced the term end of life literacy. Do you want to explain that?
So end of life literacy is similar to the issue of health literacy. Nearly all of these terms come out of traditional public health language. So end of life literacy references basically health literacy. So we know that health literacy is something that we share among ourselves, that we learn about, for example, nutrition. We know that eating right's really important. You can't eat carrots every day, day in and day out, because you'll end up poisoning yourself, right? So you just have a few carrots. You know you're really not supposed to smoke. You know you can use alcohol, but you should use it, you know, carefully. You know that you're supposed to exercise. You know you shouldn't really put on too much weight. So this is all health literacy. If we go out tonight, Mary Lou, you and me, and we go to a restaurant and I order battered fish and chips, you'll tell me, Allan, that's a good choice because I've been to this restaurant before and they do a beautiful battered fish and chips. So that's the end of that conversation. Tomorrow night we go out again because you don't want to cook. And we go out to the same restaurant and I order battered fish and chips. And you'll say to me, Mary Lou, you'll say to me, you really like that. You're having it again. And I say, yes. So that's the end of that conversation. And then the third night, you still don't want to cook. So we go back out to that restaurant again. The third night, I order the battered fish and chips. You say nothing. And then on the fourth night, we go out and I order the battered fish and chips. And finally, you say, Allan, you're going to kill yourself eating this fish and chips every night. Order something else. Order the hamburger. So basically, you're my peer pressure around my peer support, around my health literacy in the matter of nutrition. And it's the same. We do that for each other. We learn about what's good and what's not good, what promotes our health, what's injurious to our health, what is bad for our safety, reason why we put on our seatbelts, whether it's law in your state or not. We put a seatbelt on because it's harm reduction, right? Most of us know that. We wear a bicycle helmet for the same reason. End-of-life care literacy is based on exactly the same principle. If someone cries and says their dog has just died, what should you do? If you had some end-of-life literacy, the first thing is listen. Don't start talking. Don't start talking over them. The dog has died. Listen. Listen to the story. Ask about it. Encourage them to talk. That's the principle. Grief 101. Listen. Listen. If you can, if it's appropriate, rest a hand on their shoulder. Give them a hug if that's culturally appropriate. Don't do that to me. I don't like it. But for many people, they don't mind it. But this is all about end-of-life literacy. It's the same. Same when you're talking to someone with life-limiting illness. Remember, dying is not a car crash. If you read the literature on dying in the palliative care literature, it looks like a train wreck. It looks like a car crash. But that's not what dying is like. There are a lot of good things that happen while people are dying. They grow closer. There is more intimacy. There is courage. Yes, there's fear, but don't forget there's also courage, which is a good thing. There's love, there's patience, meaning-making and transformation, review and reminiscence. There are a lot of good things, meaning-making. We forget that. It's important then that when we think about dying, we think about not just the bad things, aspects of suffering, but also the positive things. Now, only end-of-life literacy, only if you learn about what death and dying is like, learn about grief and bereavement, learn about caregiving. Yes, caregiving is difficult. It can lead to burnout. It can lead to stress and depression, but there are good things about caregiving too. So literacy allows us a more balanced understanding. So end-of-life literacy is important. And it's gained by studying and by learning and by information sharing. And some of that is done on social media, and some of it's done didactically in schools and by education programs run out of palliative care services or primary care services. And some of it's done through cultural sites like museums and festivals and artwork. But end-of-life literacy is very important. The more we hide death and dying, the more we create ignorance, the more we fear, the darker the place becomes. And literacy opens things up, lets the light in, allows for discussion, allows for support, reaching out to others in an informed, a healthy way.
Good. Well, thanks. So I'm going to move on to the next topic, and that's the pandemic.
The pandemic.
We're living through an unprecedented experience in our lifetimes with the coronavirus, and it's taken a heavy toll both in terms of lives lost, but on the physical well-being, the mental well-being, the spiritual well-being of millions of people, especially the socially vulnerable who are challenged by poverty or pre-existing mental health conditions or lack of housing, or the socially isolated or the frail. And many people have not only died of COVID, but they've died with COVID. And their dying experience has not been able to have the quality of the support from their family and friends. So what can we learn from the compassionate community perspective from this pandemic?
I think the most important thing is for nearly all compassionate communities and compassionate cities to emphasize the importance of social relationships. One of the problems with physical isolation, social distancing, which is really physical distancing, is that we must ensure that physical distancing doesn't turn into social distancing. We've got some very bad practices around nursing homes and funerals and crematoriums at the moment. Despite national policies and even regional policies, there are some care homes and there are some funeral rituals, funeral and crematorium companies that are still keeping their families away. And this is a really bad idea for a whole range of reasons. There's no point in being healthy if you're lonely. There really isn't. Social support is absolutely crucial. And one of the kind of ironic gifts of the pandemic is that that's really highlighted the importance of our need to be together and to support each other, right down to even touching each other. So this is a real challenge for us. And I think those of us who are interested in the public health approach, and I don't mean infection control, and there's been, I think, around the world, a little bit too much voice from the infection control people and not the social support people within public health. The social support people in public health, the people with a social model of health, know that whatever form of isolation practices we need to put in place, we also need a robust model of allowing people to continue to support and relate to each other. Because that is the meaning. That is the meaning of life. That's why we live. We live for each other. We mustn't forget by trying to save lives that we're not saving the relationships that make that life worth living. And that's particularly important in care homes and in intensive care units. Now, in people midlife, they can still use texting and phones and other forms of communication. They can use their iPads and so forth. That's not always the case in care homes because people are living with dementia and so forth. It's certainly irrelevant in the case of keeping people away from their deceased family and friends and funeral rites and cremations. So there needs to be ways in which people need to put their thinking caps on about the alternative ways that they can continue to with their relationships, whether people are dying or dead or grieving in the pandemic. And it's important for people like ourselves and Compassionate Ottawa to make sure that this kind of principle remains in the public eye. And in public health, we call that social marketing. It's marketing not just good health and well-being, but marketing the critical importance of social relationships to health and well-being in the pandemic. And that's what we are trying to do here. And some of my work with the Royal College of GPs is about being interviewed by the media, the local newspapers, making sure that we've got lots of stuff out on social media to remind people of the importance of social relationships and to lobby their local governments and so forth to make sure these don't slip off the agenda in the kind of hypochondriasis and panic around merely saving lives instead of saving quality life, quality living with the virus.
Yeah, I think that one of the opportunities that the pandemic has created is, for the first time in my memory, people and politicians and the media are talking about death and dying. There's an awareness. It's a timely kind of issue. So I really like your idea of social marketing and really reframing a healthy situation as not just preventing you from getting the coronavirus.
Yeah, no, I'm a little bit critical on the issue about a public discourse around death and dying. I don't welcome every public discussion of death and dying. And one of the things I've noticed, certainly in Britain, is a return to a national discussion about death and dying, which reminds me of the 1950s. I don't want to talk about death and dying if these are boogeymen, or bogeymen, things that frighten people. And there is a lot of fear mongering going on in some of the public messaging, and I'm not happy about that. There is this idea that dying, or the possibility of dying, is a train wreck coming back at us again with these very old-fashioned ideas about dying, particularly dying for older people. There are more positive messages that we can promote in this kind of area, and same with the care of people who are grieving, having lost people who have died from the COVID virus. Where there's a bit of, showcasing these people as disaster survivors. And that's a very negative imaging of what grieving is like. Yes, and again, there is suffering with grief without any doubt at all. However, it's not all a black picture. And unfortunately, when recent media portrayals of death, dying and grieving have been very black, and that's been destructive. And it's set many of our kind of public education programs around grief and loss back, actually, set them back, because that more positive messaging around support and about personal growth and about hope have taken more of a back seat in the idea to use grief and death as things to frighten people, to conform to infection control measures.
Do you have any, based on your experience there, any specific suggestions, not for Compassionate Ottawa, of course, but there's many people, I'm sure, in our listening audience who have an opportunity maybe to generate some of these messages that you're talking about.
I think it's very, very important that the public message that we care comes across in this kind of environment of disaster, because there is a sense in which the public feels they're in the middle of a public health disaster, you know, but there is a little bit too much catastrophizing around that, if I could use that word. And what's more, the messages of kindness and of support are a little bit overwhelmed there. So I think organizations like Compassionate Ottawa, and in fact, workplaces with a lot of employees and schools, it's very important to say, not just push the social distancing and face mask wearing message, but the other even more important message is we care. We want to support you. If you or your family have COVID at home, we want to help. We want to be able to, you know, our people will go to your door with the weekly shopping. We will Zoom on you regularly. We will make contact with you regularly. We will welcome you. Your job will still be here when you come back. Those are the kinds of things that need to balance the kind of more conservative public health messaging, which is about harm reduction with well-being. And I think that as long as our social marketing is well-being oriented in the context of the other public health messaging around harm reduction, we'll do a good job. But that messaging must come from our business leaders and our leaders in the faith groups and our cultural leaders and our schools and universities. The positive messaging around care and kindness and support and compassion.
And just resilience.
And resilience, yeah. Not just about wearing a mask,
yeah.
Not just about social distancing.
So that's a terrific note to wrap up on, Allan, because we have not unexpectedly used our allocated time. I'm getting notes from Paula. Okay. So, but there, and I'm sure there are many questions from our listeners, and we'll try to address as many as we possibly can. But you know, this has been terrific, informative, and provocative as always.
Was it provocative? Was it? I hope it wasn't too provocative, but anyway, yes. Good talking to you, Mary Lou.
Paula?
All right, thank you, Mary Lou, and thank you both for such a very stimulating conversation. It's been wonderful to listen to. We do have some questions that we've received, and if there are any that you would like to try to sneak in there on the Q&A box on Zoom, you're welcome to submit them. And if you're watching on the YouTube live stream, you can submit them in the live chat. So the first question is, how can we discuss end-of-life care when many doctors do not see when the patient with chronic illness is beginning a slow process of dying? So they do not even think of quality of life care instead of emergency save the life care.
Would you like me to start that, Mary Lou?
You could, go ahead. I have some thoughts, but you go ahead.
Well, what you have to remember, the first thing to remember about a question like that is we're talking about social change. Number one, let's just remember what we're doing here. We're not changing the wallpaper in a room. It's a long and complex process. Yes, we do have a lot of medical practitioners who have problems with the idea of end-of-life care. They will fight to save your life to an inch of your life. We're always going to have that lot there. They are a special group of doctors who need our attention. And there's obviously we've got to think about a better medical curriculum, both undergraduate and fellowship level, a postgraduate, if you like. We need better continuing professional development programs within medical schools. Sorry, not within medical schools, within the medical profession. We need to do that alongside a better public education around end-of-life care. But from a public health point of view, which is what we're talking about today, those people are less important than it is getting employer groups and our churches and temples and our school principals to understand that they have a role to play too. I don't want to put it all on the medical profession. What we're talking about today is our responsibility, not the medical profession responsibility. We could have a whole new Zoom on the medical profession and death, and I'm more than happy to participate in that. But today, it's our responsibility. And there are cultures and there are groups and there are individuals for whom the discussion around dying and grieving is difficult. But the only way we're going to break through with those groups is have a broader community civic discussion where we can all participate. And then we understand where the sensitivities are and where the strategies need to be. And maybe some of those doctors will join us.
Terrific answer. I'll just build on that. Again, in a recent book chat, Compassionate Ottawa sponsored, that I participated in, talking about the book, talking about Death Won't Kill You, one of the people said, you know, my family doctor doesn't want to talk about this. And the other one said, then you better change doctors. So that's one thought that I would add. But the other thing, speaking about changing culture, I think having taught medical students and having medical providers in the family, and because there is such a discomfort among many people in the general public about the topic and different understandings, I think they tread cautiously. And so maybe if you proactively try and initiate the conversation with your doctor and let that provider know that you are comfortable with it, you're planning for the future, you want to partner with them, you might find that you will get a better response. I think waiting for them to initiate, it would not be my approach.
Great, thank you both for your answers to that question. The next one comes from our YouTube live stream. You're asked, does bereavement include the things that concern those worried about, for example, police violence that engage those in the Black Lives Matter movement? If so, how should a compassionate city group engage in this kind of issue?
Mary Lou, do you want to lead off or shall I?
Doesn't matter. I mean, I would say, I'm not sure what's happening. You go ahead. Because I'm back here.
So bereavement is specifically about the grief that a person gets from the death of someone. That's technically what the term means. And if you have a grief from someone who's died violently through, say, police action, that's a bereavement like most bereavements, in the sense that we need to hear more from what that experience is like. And there are a lot of, particularly in the United States, there are a lot of groups, victims groups, who are interested in public education, and we need to draw those people into a wider public forum. One of the problems about bereavement is that there's so little public space for us to share these experiences. So you get bereavement groups of women who have lost children, for example, women who have lost children to murder, women, families that have lost people to suicide, families that have lost people to homicide, families that have lost people in war, missing persons support groups. And they all have their own little individual things. I remember somebody saying to me, Allan, do you support dementia-friendly communities? Of course I support dementia-friendly communities, but I'm not really much for diagnostically driven community development. So in the end, dementia is important because cancer is important, because heart disease is important, because grief is important and bereavement is important. And that's why I use the term compassionate communities rather than dementia-friendly communities. A compassionate community is a community that cares about Black Lives Matter and does care about people who die in war or who die in the streets in an unfortunate interaction with police or law enforcement. It involves us all. What we're interested in is the social bond and in supporting each other through crises. And there is a sociological picture behind death and dying that we can't ignore. There is social inequality. Black lives matter because on a whole range of scales, not just police violence, but also health and illness and epidemiology and poverty, that Black people's lives are affected by social inequality so much that it kills disproportionately and makes ill disproportionately people compared to people outside that group. It's the same with Indigenous people worldwide. Their health and illness is a disaster. Indigenous lives matter from that point of view. We need to learn about what that means to them. One of the interesting things about grief and in communities like Indigenous communities and in Black communities, and similar to Jewish communities, is that each grief isn't just a grief by itself, but is a generational grief. It's a compounded grief. And that's something that a lot of people don't understand. And they therefore don't understand what is so often considered an overreaction by, for example, white communities, white middle-class communities who don't quite understand the sheer force of the passion and the anguish that representatives from these groups feel at the killing or the death of one person. And they don't understand because they don't understand the history of violence and death that community has undergone in the last 100 years or in the last 600 years. So this is where end-of-life literacy is critically important in showcasing the inequalities in living and dying and grieving. So the Black Lives Matter is an important part of that piece of the puzzle of human mortality.
Thanks, Allan. I'll try again and see if my feedback is gone. Yeah, I'm glad you highlighted intergenerational trauma in some of these circumstances, in particular in the work I did with Indigenous communities, because of the history of colonization and all of the social disruption and losses. A death in the present really triggers many of these historical traumas. And I also would add, just to distinguish grieving from bereavement, as you said before, we grieve many losses. They may not be associated specifically with a death. And I think people can grieve collectively to a collective loss. I think people are grieving collectively around the pandemic. I think caregivers are often now mobilizing. I'm part of this movement in Canada called Caregivers for Change, and they're really trying to use this pandemic to launch fundamental change, because they are collectively grieving the fact that the pandemic has robbed them of their relationships and maybe the opportunities to support their older people at the end of life. So I do think it's a personal and collective experience.
Absolutely.
Thank you both again. Our next question comes from the group with us on the Zoom platform. They ask, how could death doulas assist in building compassionate communities and in increasing death literacy?
Okay, so I'll start on that. I think one of the interesting things about death doulas, and I'm a patron of the End of Life Doula UK organization here. And what I say to the doulas that I work with is that doulas often see their work with families. And that's great. But I think that an important part of a doula's work is public education. Public education. And in that sense, I think a valuable thing for doulas to do part of their time is provide some of that awareness raising, some end-of-life literacy by either writing for the local newspaper or having a blog or a vlog or a volunteering to go on a radio show to talk about the work that doulas do. Just raising awareness in the community about what doulas do is a very important public education contribution. Also, doulas see a lot of people die, and they're therefore a great source of information. They see things that most people don't see or hear and are afraid of. So it's really good if doulas everywhere created a greater social and public media presence as part of their work with families.
Okay. I would add to that in Canada, doulas are really a fairly new player in the end-of-life experience. I think not necessarily that well known. I think they play a very, very important role now, particularly in this time of transition that we're talking about, because I mean, back in the day, that role might have been played by a family member or a community member who was that person who, you know, within that very tight social network accompanied many, many people through their deaths. Culturally, that was kind of built in, and it no longer is. We are lacking. When my father died at home, it was mine and my siblings' first experience going through that event. So we really welcomed coaching and guidance. In our case, it wasn't from a death doula, but I see that as a very valuable role. And then, you know, to reinforce Allan's point, if you think about the each one teach one experience, then that individual family who has been coached by the death doula are better prepared to support others within their own social network. So it definitely is an important role to play and contributing, you know, to social change and end-of-life literacy.
Yeah, I mean, just to add there, most people who work with the dying are, in fact, clinicians. And doulas are not that. They're ordinary men and women who often have a bit of training around death, dying, and bereavement, and who come from all walks of life generally, and are companions. They're normally somebody from the community, and they're companions to families who are looking after the dying. But the most important thing is that they don't use clinicians as their role model. They already haven't used clinicians as their role model. So it's very important that as part of that, they see their work in terms not just of social caring, but public education. I'd like to emphasize that again. It's something that we're talking about with our doulas here in the UK, and it's something that is critically important because they're one of the few non-clinical people with that wealth of experience that they could share with the rest of us and share with it in a way that wasn't bound up with a problem-based gaze, which is what how clinicians approach dying and bereavement. Doulas often approached dying and grief in a well-being framework. And that framework is absolutely precious public commodity, and we need that shared.
The next question that we have is, how important is advanced care planning in helping with the level of grief at the end of life?
Well, actually, We don't know the answer to that question. I can tell you that because we've been reviewing the literature recently. There's a lot of people who assert that advanced care planning makes a difference. And we've got some small studies which show that it seems to make a difference. But part of the problem with advanced care planning is the obsession with treatment plans. And one of the things that we're doing at the Royal College of GPs in the UK is redoing our understanding of advanced care planning. In fact, we're calling it advanced planning. And we're encouraging clinicians to lead with the question, what's important to you in life? And then from the question about what's important to you in life, we can then start talking about, well, if you had a serious illness or an accident, how would you aspire to keep those things that are important to you in life in that context? What things would you like to see happen? And these kinds of conversations can then lead to conversations about resuscitation and preference of a place where you would like to die and so forth, and the kinds of treatments you want. But those conversations should be an important part of primary care conversations throughout life. They're not the conversation you broach to somebody who's 84 years old and only once, or somebody who has a stage 4 cancer at the age of 45 and you've decided that you need to have an advanced care plan in place. It's really weaving the idea of advanced planning as part of the relationship between yourself as a citizen and your ongoing relationship with healthcare providers. So is that it's not a surprise and not a scary conversation that you're used to when you go to your doctor to get your antibiotics or your contraceptive or your flu jab that year, that somebody sits down and talks to you and has that conversation again and again. So is that your healthcare providers get a good sense of an understanding of who you are and what your preferences are and how they evolve. Nobody makes a will once in life. They make several wills, and the wills change depending on what age you are and the circumstances of your life. Advanced planning should have the same kind of dynamic feature. And there's a huge pressure of healthcare professionals to metrify this, to have a metric, to make sure that there are very specific questions about resuscitation, antibiotics, place of death, and so forth. And these things don't mean anything because they keep changing. And so it's very important that advanced care planning isn't reduced to some kind of questionnaire that a clinician feels that they've, deployed and you've filled in and we're all set and ready to go. That would be my comment on that.
I really agree with that. I would distinguish between medical directives, which are very specifically treatment-oriented decisions around end-of-life care about things like resuscitation and that sort of thing, with the kind of thing that Allan's talking about. He's calling it advanced planning. They're really conversations about people's values, preferences, and wishes. And I think they're very, very beneficial for two reasons. For the person who is sharing their wishes with, I hope, their family, and in particular, the person who would be their substitute decision maker in the event that they couldn't make these decisions, themselves. But sharing their values, because it allows them to feel a sense of control over an experience that has a lot of elements in it, ill health, that you don't have much control when your body is not behaving. And for the family or the substitute decision maker, it's a very good thing, because when they feel they have that responsibility to act on behalf of their loved one, they feel like they have a sense of direction and they have a basis to make some choices. And frankly, I've been told by many people, they want to do it to avoid conflict amongst their loved ones at the time when they are critically ill. They don't want the family to be fighting about resuscitation or extending life. So I think, fundamentally, advanced care planning really doesn't have anything to do with dying. It has to do with conversations with the people who are most important to you about your values, preferences, and beliefs.
Great, thank you. And thank you to everyone for submitting your questions. Unfortunately, we have reached the end of the time that we have available for the Q&A period. So I'd like to invite Monica Patton to come back on the screen and give us some closing remarks.
Thanks, Paula. And my head is so full of, and my notebook is too, wonderful phrases and ideas. And I just have to say what an honor it is to thank both of you, Mary Lou and Allan. You have informed us, you've challenged us, you've inspired us, and actually you've given us hope for our community, and I hope for all communities. We have a lot that we can build on in what you have, how you have inspired us and what you have said to us. So thank you for your time and taking the time so that we could listen to your conversation. And I want to thank all of you who have joined us, just over 300 people from around the world. I hope you have found this conversation stimulating and helpful as I have. I want you to know that the conversation will stay on YouTube. Please watch it again. I sure intend to. Please tell others to watch it, and it will be on our website soon, and we'll let you know when that is going to happen so that you can visit it there. And I hope that you'll join us for our next conversation. It's going to be on November the 25th. We'll be sending out a lot more material about that, but I want to tell you that we're going to hear some community leaders from right here in Ottawa who are working hard to care for those who are especially challenged in this time. I liked your phrase, Mary Lou, when you talked about the socially vulnerable people. And we're going to have a conversation about care for those among us. And I know that what we're going to be talking about is going to be the same in communities across and around the world and across the country. So I hope that you will join us for that. You're going to be invited to fill a very quick feedback form that Paula will be making available. We want to be sure to hear your views about this morning's conversation so that we can build on them, and particularly what you'd like to hear from us in the future. This is just the beginning. We hope to continue this over the next several months to bring you stimulation and challenge and wisdom of people who are great leaders and who are and going to encourage us through the conversations that they have. So thank you so very much. Merci. À la prochaine.